Good afternoon, folks. Now, discussion A, we are discussing Medicare's gap for care for elderly. So, here I've done a little narrative for you for A. So, let's jump into the narrative, please. Okay, the gap begins quietly, not with a policy briefing or a budget line, but with a small domestic moment. A daughter noticing her mother's hands tremble as she buttons her blouse, or a spouse realizing that the bills have gone unpaid for 3 months. Long term care rarely announces itself, it arrives in increments, subtle enough to ignore until it isn't. The slow arrival of need. My patient, Miss K, used to bake bread every Sunday. Her daughter told me that. The smell filled the house. Yeast, warmth, a kind of weekly promise. When arthritis when arthritis stiffened her fingers, she stopped kneading dough. With memory loss, when memory loss crept in, she stopped turning on the oven. By the time she entered my clinic, she needed help with nearly every activity of daily living. Her daughter asked the question families ask every day: what does Medicare cover? I watched her face change as I explained the truth. Medicare would cover short-term skilled nursing after hospitalization. It would cover intermittent home health if a nurse or therapist was needed. It would cover hospice when the time came, but the long, slow work of helping her mother bathe, dress, eat, stay safe with and remain dignified, the very care she needed most was not covered. The daughter nodded, absorbing the blow. So the part that lasts the longest, she said, is the part we're out on our own for. A system built for for a different era. Medicare was designed in 1965 when life expectancy was shorter and chronic frailty was not yet a defining feature of old age. The architects imagined acute illness, not years of cognitive decline or physical dependency. They built a program for hospital stays and for rehabilitation, not for the daily labor of caregiving. Today, 70% of Americans who reach age 65 will need long-term care, yet Medicare covers almost none of it. The mismatch is not accidental. It is structural. We have stretched human longevity without stretching the policy scaffolding that supports it. Families fall into the gap. They fall hard. The cost of the gap. Miss K's daughter began calling agencies. A home health aide would cost 25 to 35 an hour, $25 to $35 an hour. Assisted living would exceed $5,000 a month. A nursing home could reach $120,000 a year. Her mother's savings, carefully built over decades, would last less than 2 years. She asked about Medicaid. I explained the spend down rules, the asset limits, the waiting lists, the reality that Medicaid pays for nursing homes far more readily than home care. So keep her at home, she said. We have to pay out of pocket, but to put her in a nursing home, the government will help. She paused. That feels backwards. It is. The human cost. The financial strain is only half the story. The other half is emotional. Daughters quitting jobs, spouses lifting bodies heavier than their own, siblings arguing over who will take the next shift. Caregiving becomes a second full-time job layered on top of grief. Miss K's daughter began arriving late to work. She used vacation days for medical appointments. She slept lightly, listening for her mother wandering at night. She loved her mother fiercely, but love does not replace a workforce. The gap between what Medicare covers and what older adults need becomes a gap between what families can give and what they can sustain. The policy failure. When we treat long-term care as a private burden rather than a public responsibility, we rely on family caregivers as an invisible workforce. We allow Medicaid to function as the de facto long-term care insurer, but only after families have spent down nearly everything. This is not a neutral design. It is a choice, one that shapes who ages safely and who ages at home and who ages in crisis. A modern society would not require personal financial ruin as the price of frailty. A daughter's question. Months later, Miss K's daughter asked me something I still think about. Why does Medicare cover the part of aging that lasts weeks, but not the part that lasts years? There is no gentle answer. Medicare was built for a different world, and we have not built it for the one we live in now. The call beneath the story. Long-term care is not a niche issue. It is a universal one. The gaps in Medicare are not abstractions. They are lived realities in kitchens, bedrooms, and hospital rooms across the country. They shape whether older adults remain at home, whether caregivers remain employed, whether families remain intact. The daughter's story and her mother's are not exceptions, they are the rule. And until policy catches up to the biology of aging, families will continue to shoulder a burden that was never meant to be theirs alone. Okay, guys, here's the second half of A for you. It's the title is Closing Medicare's Long-Term Gap. A system built for acute illness, not for aging. That's the second title. Medicare was created to insure older adults against medical costs, hospitalizations, physician care, and short-term rehabilitation. It was not designed to support the long arc of dependency that now defines aging in the United States. Key demographic realities. 70% of Americans turning 65 will need long-term care. Most will need support for months or years, or not days. Long-term care needs are driven by dementia, multimorbidity, frailty, and functional decline. Conditions Medicare does not structurally cover. Medicare's benefit structure still assumes illness is episodic, recovery is expected, care is clinical, family support is infinite. These assumptions no longer match the biology of aging. The structural gap in Medicare: exclusion of long-term care custodial care. Medicare covers hospital care, physician services, short-term skilled nursing, intermittent home health, hospice. Medicare does not cover nursing home care beyond rehab, assisted living, memory care, home-based personal care, long-term dementia supervision. These exclusions, this exclusion is the single largest driver of financial strain for older adults and families. Fragmentation and episodic care. Fee for service. Medicare pays for the ambulance ride after the fall, not the home based support that prevents the fall. Older adults with frailty or dementia interact with multiple specialists, none responsible for the, the trajectory of decline. The results: avoidable hospitalizations, revolving door rehab stays, poor continuity, caregiver burnout, misalignment of the skilled nursing facility benefit. The 100-day SNF benefit is designed for rehabilitation, not long-term care. Families often discover the distinction only when the benefit ends and the bills begin. Consequences: premature discharges, unsafe home transitions, and increased readmissions. Hospice, hospice as the only comprehensive long-term care benefit. Medicare's hospice benefit is robust, interdisciplinary, and supportive, but restricted to the final months of life. The years of decline before that receive no comparable coverage. This creates a paradox. Medicare fully supports caregiving only when death is near. Impact on families, states, and the health system. Financial strain. Typical costs in Pennsylvania and nationally. Home care 20 25 to $35 an hour. Assisted living 4,500 to 6,000 a month. Nursing home 100,000 to 140,000 a year. Families spend down assets rapidly, often to Medicaid eligibility levels. Medicaid as the de facto long-term care insurer. Medicaid, intended for low-income Americans, now funds the majority of long-term care, but access requires asset spend down, income limits, state-specific eligibility, long waiting list for home and community-based services. This creates inequity and institutional bias. Workforce strain. Long-term care workforce is unpaid, understaffed, and aging. Medicare's inclusion of long-term care suppresses wages and limits workforce growth. Caregiver collapse. Unpaid caregivers provide the majority of long-term care in the US. They experience lost income, physical injury, chronic stress, reduced workforce participation. Caregiver strain is a predictable policy outcome, not a personal failure. Policy options for federal reform. Create a Medicare long-term care benefits. A modern benefit should include home-based personal care, dementia-capable services, caregiver training and respite, functional support, not just skilled tasks. This aligns Medicare with the realities of aging. Integrate Medicare and Medicaid for dual, dual eligible dual eligible older adults experience the worst fragmentation. Integration should unify benefits, streamline care conditions, eliminate spend down requirements. Standardize long term care access nationally, expand home and community based services. Federal investment should increase home and community based services funding. reduce wait lists, incentivize states to rebalance away from institutional care, support aging in place infrastructure, professionalize and stabilize the long term care workforce. Federal policy should raise wages, create training pipelines, support career ladders, fund dementia specific competencies. A stable workforce reduces hospitalizations and improves quality of life. 5. Build a national long term care strategy. The U.S. needs a federal long term care benefit, standardized quality matrix, financing models that reduce reliance on Medicaid, integration of medical and social care. Long term care must be treated as essential infrastructure. Medicare's long-term care gaps are not accidental. They are structural, historical, and politically sustained, but they are solvable. Aligning Medicare with the realities of aging would reduce suffering, stabilize families, and strengthen the healthcare system. This is not just a policy problem, it's a national moral choice. Okay, guys, that is A for you. I will be back on with B shortly. Give me a bit for that, please, and I will have that for you shortly. For now, Gator Wellness, take care, folks.